want to be using an extremity cassette, and you will know if it's an extremity cassette depending on the clinical affiliate that you're with and how they are the extremity cassettes. You are going to place the patient's finger, and for this purpose, we're going to use the middle finger. The finger is going to be in the center of the cassette. Our central ray location is at the PIP or the proximal interphalangeal joint space. 40-inch SID. And you can culminate down to just this finger unless your SOP at your site states otherwise. Make sure that your marker is in the light. You also, so your center of your cassette is here and here, so you want to make sure that your finger lines up right in the center of the cassette. So the patient has a shield on their lap, 40-inch distance. Just inform your patient not to move prior to making the exposure. All right, the next projection will be your oblique finger. You will have your patient roll their finger up approximately 45 degrees. You may want to place a sponge underneath there to help your patient hold this position. If you are using the second digit, you may want to roll into a medial oblique instead of a lateral oblique, and this way it helps with the finger getting closer to the cassette. So we'll go back to the middle finger. Roll up approximately 45 degrees. Still 40-inch distance, center to your cassette, shield on the patient. Ensure that your patient does not move during the procedure. We will now move on to the lateral finger. For this one, you're going to have your patient flex the rest of their fingers out of the way and keep their finger of interest straight out. So go ahead and flex, turn up on the side. Now with this position of the middle finger, you can either have the patient turn their hand this way or turn it over the other way. Turn it this way, okay? For the second digit, you would keep it turned in like this because it keeps it closer to the image receptor. For the fourth and fifth digit, you would turn it the opposite way. You always want to have your body part as close to the cassette as possible. So we will now go back to the middle finger. And for her, we'll go ahead and turn it the other way because it's closer to the image receptor. Make sure that you get those other fingers flexed out as much as you possibly can. So we're just seeing the one finger. Same central ray location, the PIP. Right, and if some patients are having a hard time flexing their finger all the way out, you can always give them a pencil, and they would place the pencil up against the eraser end, up against the finger. They would hold that with the other hand, because the eraser would be radiolucent, so you would not visualize that. It would not interfere or be an artifact on the finger, on the radiograph.
Okay, so now that we've seen the video on how to properly position the patient, let's go ahead and look at our finished product, so our radiographs that we just took. So this is a radiograph of the fifth digit, or the little finger. The first image is the PA projection, the next one is the oblique projection, and the last one is our lateral projection. Now remember, we are going to be centering at the PIP, or the proximal interphalangeal joint, at a 40-inch SID with a perpendicular beam. Can any of you locate the PIP joint? Very good. It is right here. So this is our PIP joint. So let's review our anatomy. What should we see on this radiograph. We should see the distal phalanx, which is right here, and this little bobble or bulge is going to be known as the tuft. We then come down, and this is going to be our distal interphalangeal joint or our dip joint. We then have our middle phalanx of the 5th digit. We have our proximal interphalangeal joint or pip joint. We then have our proximal phalanx. Coming down, we have our MCP joint or the metacarpal phalangeal joint. We then have the metacarpal of the 5th digit, and then we have the carpal bones down here. Now, in order to have a good radiographic criteria, we need to have soft tissue. We need to have fine trabecular markings on the bones. We need to have from the distal aspect of the phalanx all the way down through the middle portion of that metacarpal of interest. And all the joint spaces should be open within the radiograph. Now, how do we make sure that our joint spaces are going to be open? We want to make sure that our digit is going to be parallel with our image receptor. So you don't want it slanted upward or downward. You want it to be parallel, and that's going to give it an open joint space. Also, part of the radiographic criteria format is that there's no artifacts that are going to be superimposing the structures of interest. So we don't have any artifacts present here, although we do have artifacts on the radiograph. The marker is an artifact, although it's mandatory that it's there, but it is an artifact. But as you see, it's out of the anatomical structure, so that's okay. The reason why this technologist chose to put a computer-generated marker on here was because the lead marker was clipped off, and they just wanted to ensure that everybody knew that that was truly the left 5th digit. Now, how can we tell that the patient is in a true PA position? Well, you can look at the concavity of the phalanx. So as we come across here, this would be the concavity or the lateral margins of the phalanx. So you want them to be the same depth on either side, and that's going to help ensure that the patient was in a true PA position. Now, this patient here was slightly rolled up because you see more concavity on this aspect of the phalanx than on this aspect. You see how this one is a straighter edge than on this side? So the patient wasn't in a true PA position, but whenever we're looking at a radiograph, we have to determine, is the positioning of the patient worth having to do a repeat on the radiograph? Because we have to think about patient safety and ALARA. So we need to ensure that it's at least diagnostic quality, although we always want to try and get an optimal quality. Moving on to the oblique of the 5th digit, you can see that there's more concavity on this end, and that's because the patient has been rolled up to a 45-degree obliquity. We do this, the oblique helps us to be able to determine if there's anything else going on in that region. Now remember, we have to have at least 2 projections 90 degrees from each other. We typically want either an AP or a PA and a lateral, and that's going to look for fracture alignments, foreign bodies, anything abnormal going on within that anatomical structure. But we add an oblique when we're interested in joint spaces. So if there's joint spaces within the anatomical structure that we're radiographing, we like to add in an oblique because that helps us see the structures from a different perspective, so that if there is a fracture and a piece of bone has chipped off, we will be able to better identify if that is invading into the joint space, which could cause further problems. So usually we add the oblique if there are joints within the anatomical structure of interest. So as the video said earlier, you're going to rotate your patient to a 45-degree obliquity. You're still going to enter in at the pip joint with a 40-inch SID and perpendicular beam. So it's the same radiographic criteria. You want to ensure that the patient is in an oblique. You want to try to ensure that the patient's digit is parallel with the image receptor so that the joint spaces remain open. And as you can see, the joint space here and here isn't open. And it's because the patient flexed their 5th digit a little bit more than they did in the PA. So you see that curve there? That just means that they didn't keep their digits straight and parallel with the image receptor, which would result in an open joint space. We don't have overlap of any other bones that would diminish the view of the 5th digit. And as long as you have a marker someplace within the image, we do not need to put it over here as well, because we know once we started with the left 5th digit, the technologist should have remained with the left 5th digit. Moving onward to the lateral, we're going to put that patient finger up in a lateral position so their hand is going to be resting on the medial surface or the pinky side. As the video stated, you want to bring the unaffected fingers flexed as much as you possibly can out and away from that digit. Now, it may be difficult depending on the trauma of your patient, the swelling that's going on within the hand, but we want to pull that digit of interest away from the rest of them as much as we possibly can. So we want the patient in a true lateral position. We want that digit to be as parallel as we possibly can. And remember, you can turn it to rest either on the medial aspect of the hand or the lateral aspect of the hand, whichever is going to get that digit as close to the image receptor as possible. Now we see the open joint spaces on this one. So you see that black line? That's indicating an open joint space. That would be the distal interphalangeal joint or the dip joint. We then have our pip joint, which is right there. Now we're not going to be able to really visualize that MCP joint or the metacarpophalangeal joint because we have the rest of the metacarpals that kind of superimpose there. So there's not really a whole lot we can do. The phalanges are movable. So our fingers, we can move those around, but as far as the palm of our hand, all we can do is cup it, but they pretty much stay aligned. So there's really not a lot we can do about that. But we do want to at least see the distal aspect of that digit. So we have now completed this module of the PA oblique and lateral 2nd through 5th digit. The next module will include the thumb and the hand.